It's Monday, March 22, 1999, and I am sitting in the office of Dr. Ezra Greenspan at 1045 Fifth Avenue, and we're going to chat about Ezra's roles, multiple roles at Mount Sinai, and the development of chemotherapy at the hospital under his leadership. Ezra, to start off, why don't you tell me a little bit about your background, so we could sort of get you up to date, your training and all that, and up to the point where you really got involved in chemotherapy.
Well, I was strictly a Brooklyn nature boy until I went to Cornell and graduated from Cornell to enter NYU Medical School, where in an accelerated program of 999, because of the war, oncoming war, we had the most intensive clinical training you can imagine. And among the outstanding faculty people in NYU, there were several Nobel Prize winners, and in addition, I had the unique opportunity of taking certain electives and working with people like Arthur de Graaf and Batterman, who had developed Demerol and important forms of other drugs, particularly standardized digitalis into digoxin. So I got a little bit of clinical testing experience as a third-year intern, as a third-year student rather, at NYU. And then I went to Memorial Sloan Kettering and then achieved a lot of experience in Kaposi sarcoma at the lymphoma clinic of Sloan Kettering, which was a unique gathering place for Kaposi sarcoma of the old-fashioned type. It was a magnificent place to study this disease. But my real introduction to cancer per se came when I arrived at Mount Sinai Hospital as a lowly intern on Baehr service. First, I was impressed with the manner of conducting rounds, which was absolutely unique as far as I was concerned. I mean, it was run like the Army, with all kinds of rules and customs and costumes and so forth. And it was dramatic. It was intense and dramatic. And as luck would have it, the very first time I went out on the ward as the lowest man on the ladder of a group of some 18 people around bed 27 in a 27-bed ward, the higher-ups were talking about a case they couldn't diagnose that'd been sitting around for almost a year without a definitive diagnosis. Apparently some form of bizarre heart failure. To make a long story short, it was a man who had a liver and a spleen and ascites and edema and so forth, and nobody could figure it out exactly. When the sheet was lifted up off his legs, I saw one tiny purple patch at his instep, and that told me that he had Kaposi sarcoma, old-fashioned type. So, at the end of the rounds, I said, I think this man has systemic Kaposi sarcoma for many, many years. And now what you're seeing is the end stage. Well, this automatically, yeah, I'll take it.
Okay.
I'll take it. That's automatically set an uproar and a whole new tone of events. I gave grand rounds on systemic Kaposi sarcoma, which was rare as hen's teeth. There were 4 cases in the entire Mount Sinai hospital literature from the day they kept records at the hospital. 2 of them were one child, one a young adult. And subsequently, I got involved when I switched to the Snapper service in other esoterica, of which the main component was Snapper's interest, from my viewpoint, in stilbamidine as a drug that worked in Kala-Azar, which had high globulins, and which might work in multiple myeloma. So my job was to infuse the patients with stilbamidine. This was an extra. This was not the regular intern's job. And at the same time, he had Schneid, his woman pathologist, looking at the smears that we made from the bone marrow. At the end of the third week, all of a sudden we see granules appearing in the cytoplasm of the myeloma cells. Well, now this was absolutely, as far as I was concerned, a world-shaking discovery, which turned out to have no clinical significance, or at least we never could demonstrate the true clinical significance of it. But if chemotherapy could localize into a malignant cell, this was the way of the future. So it was a naive, simplistic visualization of something that later on became very, very important in the cancer field. So I really became an oncologist as a result of Snapper using stilbamidine and with this crazy observation, which we went on at Walter Reed Hospital later on to study high-dose stilbamidine. It didn't do very much in myeloma, but of course we didn't study it long enough anyway. We couldn't. We may have missed something. To this day, we don't know whether we missed anything. The first drug came out at that time, first organized drug, you might say, tested drug, was nitrogen mustard from the Army Chemical Warfare Service. And we at Sinai were the fourth place to use it. There was at Sloan Kettering, Walter Reed, and Yale. Yale was the first place, and we were the fourth place to use it.
Who was in charge of using it at Sinai at that time?
I don't remember, but we had it on the Snapper service, but it was shortly after that I went to Walter Reed Hospital,
Right.
actually. I left Sinai, my 2.25 years were up. So from there, I was a non-Mount Sinai physician practicing internal medicine and doing odd things like using nitrogen mustard and stilbamidine. We even used the stilbamidine at Walter Reed Hospital for about a year and a half. So the idea evolved during the 1946 to 48, when I was at Walter Reed, that there were other drugs, mustard-like drugs, that could be used, of which thiotepa was the leading contender. There was triethylene, an oral triethylene melamine, TEM. Mm-hmm. But thiotepa, you could give it intramuscularly, give it intravenously. It was easily absorbed. It was a cinch. There was nothing to it. You could give it even subcutaneously. It didn't cause necrosis. So you really had a hell of a good drug, and it was working with thiotepa and with methotrexate, which came along at the same time. In 47, they started to use methotrexate, but they weren't sure what they had. By 48, they knew what they had. The Letterly people had given various selected institutions nitrogen-substituted derivatives of a folic acid eluate. Now, Babe Ruth, at some point between 46 and 47 and a half, I would say. We know when it was, as a matter of fact. It was in 47 that Babe Ruth, in desperate situations, was given a folic acid eluate, impure mixture, obtained from Subaru, who was the chief chemist at Letterly Laboratories in Pearl River. Now, he had been providing Lewison with all kinds of gamishes. He called them gamishes because they were impure and they were working to isolate the active ingredient. And the fact is that Babe Ruth got, I think, 6 shots, and he had a big mass in his neck, which went down. He had actually, in retrospect, we know he had a lymphoepithelioma, Schminke tumor. Right. It was a classical Schminke, and it was missed, and they diagnosed it, then they fooled around, and so forth. And then the tragedy, to end up on that part of the story, was that when he relapsed, they already had the pure aminopterin. They did not treat him a second time when he relapsed, because had they done so, they could probably have responded. He may have lived a couple of years more before. This was as a result of politics. Now, when you talk about politics, you don't know exactly who was involved.
You never know.
But we can make a very shrewd guess as to who was involved. In the first place, Sidney Farber had moved from Brooklyn Jewish Hospital as a pathologist to Boston to Dana-Farber as a clinician. He was practicing chemotherapy on children primarily, at Children's Hospital. And he was interested in what Subaru had. And I'm sure that his first materials contained what was called pteropterin. And Sidney Farber wrote a big paper, 3 pages long, or less, actually, but it was 2 columns per page, on some 60 cases, and he vaguely said he thought it did some good, but you couldn't actually pinpoint what good it did. However, he was called in, Sidney Farber was called in by Sloan Kettering that was working on the same stuff. And he told Sloan Kettering the stuff was no good. Now, when Sidney Farber told Sloan Kettering it was no good, they quit working with, quote, pteropterin. Now, whether that was some form of self-interest or whether it was just really relating what was really occurring, nobody will really ever know. But what is known is that within a month or 2 after he wrote the manuscript, he wanted to recall the manuscript, but it was already in press. So he knew within 2 months or so of the time that he submitted the manuscript that the real McCoy, the real anti-cancer drug, which was a pure nitrogen substituted derivative from the folic acid, in other words, was actually the ingredient that cured leukemia in children. So it was an unfortunate concatenation of events in which I think certain political influences and certain prestige factors played a role, but Lewison appeared to be the fall guy, even though Lewison did not protest, nor did he publish. And he certainly felt, correctly so, that the drugs that he was using, which was impure, was not yet ready for clinical use. But within 3, 4 months or 5 months, it was ready for clinical use when Subaru at Letterly Labs was able to purify the stuff. So that is the way the field evolved. In the meantime, I was totally disaffiliated from this since I was working at Walter Reed Hospital. I was away. So I was doing my own work there. And at Walter Reed, we had a wonderful drug, Thiotepa, which is still being used long after Lou Wasserman pronounced it a platelet poison, by the way. And we had methotrexate, which was made available to us. So between the combination of Thiotepa and methotrexate, 2 drugs acting by totally different mechanisms, I was able to start treating patients with cancer. And then I left to Walter Reed to become a special cancer fellow at the National Cancer Institute and to actually run the pilot plant of the new hospital. I ran the pilot plant for about 2.5 years. I was a fellow for a year and then 2.5 years. So at
the clinical center?
Yeah, before the new buildings, right. The old buildings. They're all big old wooden buildings. So I had 3.5 years of government support. And I had the most magnificent setup. I was just lucky to be in the right place at the right time. For example, Snapper came to visit me after a year I was there or so, and he came and said, "Greenspan, you will never have it better in your whole life." I said, "You're right, Dr. Snapper, you're right." I had a budget of about $20 million for an outfit that would today cost about $250 million to run it, plus 15 beds that we didn't have to pay for. So we were able to do clinical research, real clinical phase 1, 2 research, and we introduced combination chemotherapy there. And then at Mount Sinai, when I came back, I had the experience to use the drugs simultaneously and to get the most mileage out of them. But at Sinai, nobody knew anything about this because it was a practicing hospital without a medical school and without basic scientists, and there was nobody who understood what I was doing, or if they understood it, they only understood it in theory. They couldn't believe the practice component of it. So that at Sinai, I achieved a number of nicknames like Lucrezia Borgia Greenspan, the Poison King, or some things like that. But we were able to do a great deal of work at Sinai, and we're able to do work in other fields because the laboratory that the Cancer Institute gave me permitted so much leeway that we were able to stumble into a number of new observations. We were able to develop the dysproteinemic analysis of diseases with the serum mucoprotein and the serum alpha-1 and alpha-2 glycoproteins. So that I was both a protein chemist as well as a chemotherapist. And this was possible because Adolf Lewison gave me $70,000 the moment I entered Mount Sinai Hospital's walls, the very first day I came there from the...
After you came back from
After I came back, yeah. Lewison, but he gave it to me because Snapper said, give it to him. It was a combination of Snapper and Lewison that was responsible for it. So we set up the first lab. But it was a lab based on protein studies, not on cancer studies, because we didn't have the facilities to do the animal work that we were able to do in Baltimore at the Public Health Service Hospital. So I was sort of a bit of a mongrel. They used to call me Greenspan, Muco Greenspan, because mucoprotein was or else Lucrezia Greenspan. But at the same time, I kept reporting the clinical observations and the papers and so forth. So it took about 8 years at Mount Sinai Hospital before most of the people at the hospital began to think that maybe I wasn't crazy, or a money grubber, or self-interested, or whatever. They didn't look at me as a queer duck. It took about 8 years. But I remember very well Bill Hitzig telling me, Ezra, I've never seen a case of chemotherapy response. I said, you haven't? Well, that's your fault. I said, what about your friend, Mo Spahn's wife? Oh, he forgot about her completely. I had to go to New York Hospital to treat her. She had cerebral metastases from breast cancer, and she responded brilliantly to methotrexate thiotepa. So it was an odd set of circumstances at the hospital.
While Jackie, line 1.
While the hospital encouraged research in there was a certain type of freedom. There was cantonization in the hospital. I call it the greatest cantonized hospital, clinical cantonization. I mean, I said to myself that only at Mount Sinai could I have been worked there, and I worked there for 15 years before we had a medical school. And the interesting thing, I did all the work on mucoprotein and differential diagnosis of jaundice, and for a while it looked like very big stuff because there was so much liver disease in Africa and other places like that. But then electrophoresis, quantitative electrophoresis came along and sort of put it out of business. Sheila Sherlock put it out of business too. The fascinating thing from my viewpoint was that I had this freedom to work at Mount Sinai Hospital, and I had the greatest respect for the hospital. And I knew that there were a lot of smart people at the hospital, but they really had such a limited knowledge of the things that I was doing that it had to be not sarcastic, but you had to be indulgent, actually, is what it boiled down to. And it came to the realization after a while to people like Al Gutman, who was always a very fair guy, but who was, this is a personal thing, when I first met him, the minute I arrived back from the Cancer Institute, his office was right next to Snapper's. He had just lost his wife from leukemia. And here I am, this young kid. I can imagine what I must have looked like or felt like to Al. This whippersnapper is talking about curing leukemia, controlling leukemia, and his wife has just died. I mean, he must have really been boiling inside, but he never displayed that. But he never helped me one bit, never did anything to it. But he also didn't say anything. He never criticized me. In fact, once I wrote an article for the Mount Sinai Journal on the mechanism of action of folic acid antagonists. I wrote it was a very beautiful, extensive write-up. At the time, it was really important. Gutman says it's the best paper, and he returned it saying to me, it's the best paper he ever read on this kind of a subject, which I really took as a great compliment. Anyway, at the end, 19 years later, he kept me in the same rank, by the way. Never gave me a promotion.
What else is new?
No, wait, listen to this. But at the end, when he retired, and he had to write up a grant for the medical school in cancer, he calls me in. So I said, so I go into his room, and there he is, puffing away cigarettes. And his first thing out of his mouth was, Greenspan, I'm not shitting you. Now, here's a word. I mean, he would never use. This man would never say. He says, "I'm not shitting you. We didn't believe a word you said." Oh, I said to him, "Now, Dr. Gutman, don't worry about that. Come on, that's unimportant. At this late date, we're going to worry about what you." But he had to apologize for ignoring me for 19 years.
But he never forgot that he hadn't apologized.
Oh, yeah,
right?
exactly. Oh, no. He's a quality guy all the way.
Sure, yeah.
Listen, the work I did on mucoprotein was right up his alley, sure. and other stuff. He knew that was interesting. But he knew that wasn't my main interest, though. But he never forgave how, I can imagine what he must have felt. His wife had just died, and he was madly in love with her, I'm sure. And I come in to his office, introduced by Snapper. I start talking about treating leukemia and curing the animals as well as the patients.
When you first started treating patients at Sinai, they were mainly breast and ovary and leukemia?
There were and lymphomas.
And lymphomas.
Yeah, there were very few GI, no lungs, no.
Well, that really came along later, didn't it?
Yeah.
When you had more drugs.
Yeah.
Dr. Goldsmith?
No, they were the initial was leukemia, lymphoma, breasts, and ovary. But the reason why the breast cases were my main interest, and why they were, from my viewpoint, the most successful, was very simple. The reason was simple, because in those days, most breast cancer that I saw was out front disease. In other words, it was either chest wall disease, recurrent disease, or they had palpable disease.
Yeah, and you could follow.
I could not only follow it, the patients could follow
Sure.
it. That was the important point. The patients themselves could follow it. So, if I pushed the methotrexate, pill by pill, 9 tablets, 11 tablets, 12 tablets, whatever it was, that each, it would vary from patient to patient, but points. If I titrated them with methotrexate and with diatepa, they could see the disease melt away. And once a woman saw that happen, they were hooked. They were happy to continue. And of course, they all recurred with maybe 1 to 2% exceptions. They all recurred within 2 to 3 years. And most of them recurred by the end of the second year with diatepa methotrexate. But then in 57, fluorouracil came along with Charlie Heidelberger, and in 58, Cytoxan, endoxin from Europe. So we had 2 more different drugs, couplets that were non-course resistant. So I introduced the combination of the other 2 drugs.
Dr. Goldsmith, Dr. Rosenberg,
And then made some of them
line
3 drugs or 4 drugs, or it was 2 and 2.
Mm-hmm.
So I really introduced the whole subject.
What's the longest people will go now? Are they cured?
Oh yes, there are lots of people who are apparently cured if you consider 15 years disease-free to be
I'll
cured.
consider it.
Well, but we realize that 15 years
No, I
is
know.
no guarantee.
I know we've had
But
recurrences
the
after
point
20
is,
and more.
see, I think the true, if you ask my opinion, the clinical cure rate, using in a broad sense, let's say 15 years, the clinical cure rate in breast cancer is probably in the realm of 15%. In other words, you get a certain percentage of who, for reasons, and we know now some of the reasons, but we didn't know it then. It's immunological. It has to do with factors that are immunological, which we had no inkling until the mid '60s. It was actually the first one who introduced the concept of immunity at a practical level. Was a Frenchman. Here I'm showing my age, who introduced BCG. He's worked mostly with pediatrics and leukemia, and he was the first. He came to Mount Sinai in 1971, the first meeting of the Chemotherapy Foundation symposium.
I want to talk to you a little bit about the foundation. Let me switch this. You had just started to talk about the foundation. I wanted to talk about, when did you start that?
Well, I started the foundation when Saul Burson came to the hospital. It was shortly after I had that meeting with Gutman.
Dr. Greenspan?
I can't, she had no sense. Okay. I started the foundation knowing Saul was the chief and planning actually to move into the hospital. Back into the hospital, I should say, back into the hospital. Because when I first came to Mount Sinai in 1951, I was the first one in on the ground floor of Klingenstein there. But I found I couldn't get a chest x-ray or blood count or anything. You couldn't practice medicine. It was impossible.
I remember, I was there too.
It was a wonderful location, but it did me no good whatsoever. So I left there after a year and a half. And incidentally, Gutman sent me the first case of myeloma, just as the day I'm leaving the Mount Sinai headquarters there. And that's a separate story which we don't want to bore you with. It was quite a story. Well, anyway, the point is I formed the foundation because I felt there was a public need for a foundation for dissemination information to physicians and involved patients and sophisticated patients. The subject was too complex for unsophisticated, but very sophisticated patients could follow it. So the idea was to form the foundation, and the second purpose in forming the foundation was to act as a vehicle to set up a cancer institute at Mount Sinai Hospital. And when Saul Burson died, that was the end of my plans to move back in. I was already 53 or 54 at the time. And it never dawned on me that I was too old, or that anyone would even mention the fact that I was too old. But that was a factor. But the real factor in me not getting the job was very obvious, and it was honestly expressed by Lou Wasserman, who said when Emil Fry and Holland were the choices, well, either one will be able to bring cancer money and be very conspicuous public figures, because they had worked, well, along with the Vita, they were and Freireich, the four horsemen. They had worked at the Cancer Institute when the new buildings were formed, which were erected, which was in '56.
Right.
So they had from '56 lead time to build up their work and their reputation, and they had the lab facilities, they had everything, and they had lots of money, and more money was coming. Now, what clinched it, of course, was very simple. That, in theory, it's very nice to have a Mount Sinai man, but if you can get a man from the Cancer Institute who can bring tons of money, you're much better. But the man who really did it was Richard Nixon, because he started the war on cancer.
Right.
And with it, tons of money. The politicians got involved because Senator Vandenberg died of lung cancer. And that really set them on their ears because they never, I think he was the first important politician to die of cancer. And so from that time on, it was big business and it was different. So I stayed in private practice. The result is that I'm an anachronism. At the present moment, I think I'm the oldest practicing oncologist in the country, maybe with one exception, but he's not really practicing. No, it's true. No, that's the truth. It's true.
What do you see as the major benefits of the medical school in your field of chemotherapy?
In my field? Well, the major benefits could be tremendous, but I don't think have yet been realized.
Where should the school be heading from your point of view in cancer?
Well, the problem in cancer is so complex now. And it's a logistical problem in management of patients and in getting the medications into the patients. In other words, the treatment regimens and the patients. It's all a logistical problem. And so the institutions with the largest amount of money and publicity are the ones that are going to succeed, or with the tightest organization. Now we have, as I said, this tradition of cantonization at Sinai, which has worked out well because it permits certain individuals to do their own work undisturbed. I mean, we're a very liberal institution, Sinai is, even though people don't they don't realize it. But I realize it. I realize it all along. From the day I set foot back at Sinai, I realize it. Anyway, so in order to compete, who are you competing against? You're competing against Sloan Kettering, MD Anderson Hospital, Pittsburgh Center,
Boston.
Boston, Seattle, maybe San Diego. But the point is, it brings you around to a question of competition for new agents and the quick application of these new agents. So unless the hospital is set up to be fully mobilized quickly on whatever basis they're going to do their studies, they can't compete. And this is the real problem at Sinai as far as I'm concerned.
The wheels of progress grind very slowly, is what you're saying.
The wheels of general progress.
Right.
Yes, you have to say that.
Yeah.
Yes, I think that's the major problem with the institution.
Right.
And it becomes worse as time goes on because the HMOs are involved in one angle of it, and you got the groups like Salic and company, and they're very efficient in their way, and you got groups like Sloan Kettering who will spend millions of dollars on publicity just to bring patients in, and I don't necessarily think that any one of these approaches is ideal, or is even, or even necessarily high quality, but it will take away resources, money and manpower, both. So we've got a complex problem here. We have to create an identity, and the identity is hard to define. I used to think the best identity for the institution was human logic. So we started out with Rosenthal, and with Wasserman,
and Attenberg before them, and Rosenthal.
Well, I said Rosenthal, I mentioned that. Sure. And don't forget, Lewison was the first citrated transfusion. I mean, people don't know any medical history. No history. But it's interesting. Those were sort of individuals who they function as individuals.
Absolutely.
That was the whole secret.
It was each individual was his and it was his own, but there were no hers in those days.
That's right.
It was all his own thing.
Not only no hers, you couldn't even be married until 1937.
I know that from home. That's why I'd be older probably. Except my father wasn't allowed to get married. Okay. Well, this has been a lot of fun. What do you see as the future of chemotherapy?
Well, by itself it has limitations, but when you're talking about biomodulation, and you're talking about immunotherapy, and you're talking about gene therapy, and you're talking about angiogenesis, and the whole gestalt. Oh, I think it has an excellent future. But conventional new cytostatic agents or cytotoxic agents by themselves, the whole idea of looking for a single magic bullet is wrong. I mean, that's how I introduced my own work, really. In fact, the textbook that I wrote, that was one of the first things I brought out, was the fact that there was no single magic bullet. Ehrlich had the idea. It was an old-fashioned idea that with the right number from the shelf, you'd get the right drug. That's out.
Okay. Well, thank you very much. I'm going to turn off the tape, and then I want to talk to you a little bit about some of your papers, okay?
Yeah.